Howdy, everybody. Welcome to the 31st annual International Prostate Cancer Update, better known as IPCU 31 at the Cliff Lodge in Snowbird. And I think that's great. The bad news is after 25 years of doing meetings with DC, my endearing nickname for David Crawford, I am actually not there. So we had a series of family emergencies, a very good excuse. I won't go into the detail, but it was enough of a reason that I had to be here this week. And thanks to the staff and audiovisual, everybody at the company, as well as the meeting, for letting me do this at home. This should hopefully be the last time I have to miss a meeting, but someone has to miss a meeting within 25 years, and that's what I had to do. There's my information there. Again, I apologize for missing my first in-person lecture. Dr. Crawford's going to be moderating this session. I'll put in a couple quick words on the session itself. I'm honored to lead off like I get to be the lead-off hitter for this conference the past few years, and it's been a real honor for me. And I look forward to doing that in the future, because to me, this men's health category is one that just doesn't get enough attention at medical meetings, but we've been lucky enough through this group, through the physicians here and the healthcare professionals, they've made this a priority, and they always start the meeting this way, and I hope they continue that. So I get to start off by just talking a little bit about diet, very short, and then Dr. La Rosa gets to talk about the third dimension in prostate cancer diagnosis, which looks like a wonderful talk, as well as the early diagnosis of prostate cancer by Dr. Crawford, which is, vacillates. What do you do with that? What's the latest thinking? What's happening, for example, with screening. And then Dr. Garnick, who I really respect, is going to take us through the advances on oncology. And I've known him for a long time, and I can't wait to hear about the latest and greatest. It's been an amazing year so far, if you think about it, not just in terms of drug development and what might get FDA approved in the next 6 to 12 months, but also in terms of imaging, which has really been stunning. And then you also have Wendy Pogue, who's talking about patient advocacy. And the thing that people might not know about Wendy is I've known Wendy for almost 20 years. This is not someone who's just coming in and going to talk about patient advocacy. This is somebody that's been living it and been a leader in patient advocacy for the last 2 decades. So when she talks on this subject, we definitely listen, because we don't have people in advocacy with that kind of track record. We have very few. So I look forward to Wendy's talk. And then there's the LUGPA government policy panel, which I know nothing really about. I just know these are heavy hitters who are here, and I'm excited, but that's not my forte. But it just looks like a great session, and I'll definitely see you at the next meeting to lead off. Okay, with that in mind, I'm going to talk about diet only and prostate cancer. I'll be done within 10 minutes. Here's my bottom line recommendation. Please, just please continue to follow the lessons from breast cancer and cardiovascular disease. What does that mean? Most of the randomized data that started even decades before prostate cancer, there's been great randomized data, good studies, but breast cancer was way ahead of us. Cardiovascular disease was way ahead of us. And what they're essentially learning in both instances is that when you change a marker, when you change something that's relevant, an objective indicator, you tend to change not only the subjective, but you also can have an impact potentially on prognosis. And if you don't impact prognosis by changing these heart healthy markers, at least you're improving the quality and quantity, potentially, the quality and quantity of the life of the patient. And so it's a win-win philosophy. And we've become adopters of that philosophy over the past few years. But I hope we continue to turn that way, where we think more like the breast cancer research and the cardiovascular disease research. And we start to adopt the philosophy that essentially first do no harm. And if you're going to do a benefit, then lo and behold, there should be a heart healthy benefit, and everything else should go from there. So anyway, here's my first Go Blue dog. Let me advance it. There it is. So of course I got to throw in my Go Blue dog, our dog there. That's again to throw the big block M in everyone's face, but everybody loves to talk about dogs. You really can't talk about anything else today. You got to be very careful on what you present and what you say. But if you talk about dogs and cute dogs, everybody loves you. They give you a good evaluation. So you always start off every talk with a cute dog or your own dog wearing a Michigan jacket. Evaluations go way up. You're popular. Everyone loves you. All right, here's my quick history lesson. There were 2 major randomized trials in breast cancer long before we had randomized data in prostate cancer in terms of diet. Large trials, over 2,000 in a trial called WINS. I won't go through all the particulars. And then WHEL, W-H-E-L, over 3,000. And one goes 5 years and one goes 7.3 years. And the whole idea is taking patients with localized disease and basically doing diet as an adjuvant therapy or locally advanced disease to try to reduce the risk of relapse or recurrence. If we can do that through diet, wouldn't that be amazing? So in the first trial above, where WINS showed a benefit, the average weight loss over the 5 years was 6 pounds in the intervention group, which is just simply cutting back on calories. They went to a low-fat diet, but they reduced their caloric intake by about 167 calories per day on average. Some went much further than that, but weight loss was pretty consistent over that time period. Whereas in the other randomized trial, they improved the quality of their diet, but quantitatively, it wasn't enough to make heart-healthy changes. There were no weight loss differences. And don't you find it interesting that the one above, called WINS, was actually the winner? They showed a significant reduction in recurrence over the 5 years, whereas the other randomized trial, which was even larger, in increased fruit and vegetable consumption, did not show any benefits. So what does that mean in terms of epidemiology, which is my forte? It's if you were in this breast cancer trial and you wanted to prevent one cancer recurrence after treatment, then 38 people would have to adopt this dietary change for one person to benefit. So that's an NNT of 38. And an NNH, a number needed to harm, obviously we weren't seeing harm of that, except you just had to adopt a different type of diet where you reduced quantity, essentially improved quality, but you lost weight. There was actually a tangible heart healthy change. And so is this worth it for 38 people to make a change after surgery, after hormone therapy, after you name it, for a person to see one benefit? The answer is overwhelmingly yes, because what we've learned since then, remember these trials go back long into the beginning of 2000. What we've learned since then is that the majority of people who adopt these dietary patterns, they see benefits in terms of all-cause mortality and all-cause morbidity, and they reduce the risk of potentially of cardiovascular events, which in dealing with many of the hormone therapies, the second generation hormone therapies today and these other novel hormone therapies, we realize that cardiovascular disease prevention should be a priority. So even if it doesn't prevent recurrence, even if you're not one of those lucky 1 out of 38, the fact that it's providing heart healthy change, the fact that it's providing quality of life change is reason enough to do it. There's a third randomized trial that hasn't been published yet, though. Again, breast cancer. This is a German multi-site trial called Success-C. Look at these numbers in these randomized trials where you have an interventional lifestyle group, and then the control group usually is told to do nothing but read a pamphlet. But that's over 2,000 patients. And we're expecting data any day now or any year, but there was a interim analysis that showed that the group doing caloric reduction plus exercise had significant weight loss versus the group that was the control group. And they found that the group that adhered, that's the most important point, the disease-free survival is significantly improved in the people that adhered to the lifestyle changes, which means you're looking to lose weight and you're looking to maintain regular exercise most days of the week. So again, now we have 3 randomized trials. Again, this is an abstract. This is preliminary data, hasn't been published yet. 3 randomized trials in breast cancer, and the 2 that show weight loss and the 2 that show heart healthy benefits are the 2 that are showing the potential to change prognosis. Interesting. Same thing we've learned in cardiovascular disease. This should be applied to prostate cancer trials and thinking when advising patients, in my opinion. Well, let's talk about more history. There was one of the largest trials ever done just in metabolics and cardiovascular disease was a 2-year randomized trial out of Boston called the Pounds Lost trial. There were 4 different groups that basically changed their different macronutrients they were taking, whether it was higher protein, less fat, or adjust carbs, you name it. They looked at 4 different permutations or combinations and found, here was the conclusion after the 2-year randomized trials, that clinicians concerned about inflammation and cardiovascular risk should recommend weight loss diets most likely to succeed for their patients. The reason they came to this conclusion after arguably one of the most methodologically strong trials in metabolics, is very simple. They came to this conclusion because they showed that regardless of how you lost weight, regardless of the diet, as long as the weight loss actually occurred, then they saw the clinical benefit, or they saw the numerical benefit they wanted, AKA cholesterol, blood sugar, not just weight loss, and all the parameters that actually matter. And now we have the Duke trial. It's called Calorie, 2 years. Calorie being comprehensive assessment of long-term effects of reducing intake of energy. This is my favorite diet study done over the past 5 years. They simply told participants in the intervention group to cut back on their calories daily by 25%. They were only able to cut back on about 13.7%. Still, these individuals lost 15 pounds, and most of them were actually not obese. They were overweight or close to a normal weight. So just by cutting out 250 calories a day of whatever they chose to cut out over 2 years, they had slow and methodical weight loss along with metabolic changes, along with numerical changes that were heart healthy. Boy, isn't this the greatest message to send for this entire talk? Let's quit ramming diets down people's throat. Let them pick the one that works for their personality, and let them pick the one that they'll give the greatest adherence to, because that's what matters. So moderation plus flexibility equals winning. And now we have breaking news on a 16-week vegan randomized trial. I like the vegan diet in the sense that it's gaining momentum for multiple reasons. One, it's healthy for the planet. Two, it's healthy for the patient or the person. And three, it has a sensitivity toward preventing animal cruelty, or being kind to animals on the planet too. So for a lot of people, that philosophy makes sense. It really does. But what people don't realize is that if you go to a vegan diet versus a control here, it's a high carb diet, but it's a healthy high carb diet. And what they actually found after 16 weeks, if you look, is that patients were actually eating almost 500 less calories per day. And they were increasing their fiber, and look at the weight loss they were getting. Another message. So you can change qualitatively. You can eat more healthy, but still, to get that kind of weight loss, they were still consuming, when they moved to vegan, about 500 less calories per day than they were doing before. They also added B12 to their diet in terms of a supplement, because as we know, B12 comes from animal sources. And the reality is, if you cut out all animal sources and you go strictly vegan, one of the concerns you have is, are you getting enough B12 daily? So very smart researchers in this clinical trial also added B12 supplementation to the people that went vegan over 16 weeks. And so the bottom line is, excess of anything, excess alcohol or adipose tissue, these are carcinogens. We now have over 85 studies, 50 plus prospective in obesity, showing that obesity can increase the risk of aggressive prostate cancer. Doesn't necessarily change incidence, but it increases the risk for aggressive disease, potentially the same thing you see in breast cancer and other hormonal tumor types. And we've even seen this from our randomized trials of BPH drugs, that essentially, if you drink too much, if you gain too much adipose tissue, it can reduce the efficacy of your drugs. So what does that mean in terms of the efficacy of our novel anti-androgen therapies? If you gain a lot of weight, or if you drink too much or do something heart unhealthy in excess, does that offset the effect of the medication? Well, we see that with BPH drugs, but the bottom line is, excess alcohol and or adipose tissue is a carcinogen. Well, we had a trial called, not we, but there's a Parsons trial, great trial called the MEAL trial, active surveillance, 2 years. Long story short, you're just going to increase primarily your consumption of fruits and vegetables. You're going to go to 7 servings a day of vegetables versus a control group. There was no impact on the active surveillance patients. Why? You could argue that you see more benefit in patients that have aggressive disease versus slower disease and better prognosis in terms of diet. You could argue that the control group made too many healthy changes. So they actually cut calories by about 56 a day, where if you look over the first year or two, whereas the intervention group cut calories by 120 a day, there were really no tangible heart healthy changes. They had similar weight loss. They had similar, apparently, cholesterol changes. So across the board, even though you were improving the quality of your diet, the changes weren't dramatic enough versus the control group to see, 5-10 pounds of weight loss versus control, or 30-point difference in LDL. And I think if you're going to see a change and you're going to see a benefit in prostate, that's where you would see it. If you saw numerically, objectively, a huge difference between the health numbers, the general heart health numbers of the intervention group versus control. But who knows? Again, in breast cancer, we've learned that it's in some of these dietary randomized trial, it's people that have a more aggressive type disease are more likely to respond than those who have more of a well-differentiated disease. But we'll see. We have to learn more. It's either way, it was a great trial. I think The only thing I would tell you is the control group seemed to do a lot too. And, how do you correct for that? It's not easy. Yeah, we're getting data on lycopene. I was never a big fan of lycopene, but the truth is in 1999 was the year of one of the biggest lycopene studies by Giovannucci in the Journal of National Cancer Institute. And what he said was brilliant. He said, the data on lycopene just suggests eating more fruits and vegetables. It doesn't mean you go out and take the pills. It doesn't mean all you do is eat tomatoes. I mean, for a full 2 weeks after the study came out in 1999 that got people excited about lycopene, you couldn't find a tomato. I like to remind people that lycopene comes from diverse sources, not just tomatoes. People don't realize, this is a great quiz, that asparagus, yes, asparagus actually even has a little bit of lycopene. So it shows you whether it's pink grapefruit, guava, mangoes. What the lycopene data really shows is to increase the consumption of fruits and vegetables, not necessarily one type of fruit or vegetable. The vitamin D trials have not shown a benefit yet in terms of prevention. I won't go in here. I'm running out of time. No impact on preventing any cancer so far at 2,000 IU. This is the largest randomized trial done so far by Joanne Manson and out of Harvard, 25,000 people for 5 years versus a placebo and olive oil. There was a slight increased tick of kidney stones, even at 2,000 IU, that didn't reach statistical significance. And people should watch this. As more and more people get vitamin D, they should watch for the increased risk of hypercalcemia, hypercalciuria, because you're starting to see these in clinical trials with more and more people being exposed to vitamin D by itself. The breaking news on that study was that they thought they saw a reduction in metastatic or fatal prostate cancer or different types of cancer if those of you had a BMI less than 25. I don't even know if I believe this is real or chance. Is this cause or association? I mean, so we don't know yet, but don't you find it interesting that they're suggesting now in the largest randomized trial that if vitamin D helps patients, it helps patients primarily in those who have BMI less than 25 because they may be more sensitive to it. Another reason just to become more heart healthy when you're moving toward a prostate cancer diet. And also remember, when you leave with patients, as you get older, it lowers your blood level of vitamin D. As you put on adipose tissue, as your blood pressure goes up, your cholesterol, your blood sugar, as you increase the amount of inflammation in your body, if you don't exercise, if you smoke, and if you just sit around listening to Moyad lectures, all of this lowers your vitamin D. So what we've also learned in patients is that to carry a heart healthy profile lowers your blood levels of vitamin D. So maybe it's not the vitamin D that fights the disease. Maybe it's the disease that you get that actually lowers the vitamin D. So there may be an association here, but not causation. So again, the question you have to ask yourself, does low vitamin D cause prostate cancer? Or is the low vitamin D itself caused by the prostate cancer? And we haven't figured that out, but remind patients that being heart unhealthy lowers your vitamin D anyway. There's my Go Blue dog. I am finishing up here. And I was going to talk about metformin. And I won't go into this too much. It's showing a benefit potentially for heart healthy and breast cancer. It's shown a benefit for some ADT patients in terms of lowering weight. And a trial just came out in the past 2 weeks called MansMed, which they looked in a randomized trial, metformin plus standard of care versus standard of care alone. And at 22 months, they are seeing a potential benefit of using metformin. But what if metformin fails? Here's what I'll tell you. Metformin originally became famous in 2002, where it showed a 31% reduction in 3 years in terms of pre-diabetics becoming diabetics. So we know it reduces risk of diabetes. And after 10 years, it was 18%. But there was a third group in that trial, in the diabetes prevention study group, and that was a lifestyle change group that reduced their caloric intake by 450 calories a day, and they exercised upwards to about 150 minutes a week. And look at their data. In the same trial, they reduced the risk of diabetes by 58% at 3 years and 34% at 10 years, statistically significantly beating the drug. I don't talk about metformin or statins. I don't talk about it because I think it's going to be the saving grace and the add-on adjuvant for prostate cancer. I talk about it because it's a first do no harm approach, that if all we're doing is still reducing the risk of potential pre-diabetic from becoming diabetic, or helping them lose weight, or helping them control their insulin levels, then they're still winning here. And it's generic and it's cheap and it's natural. It comes from the French lilac. But just remember, at the end of the day, lifestyle beat metformin in one of the most rigorous trials ever done to look at the risk of diabetes. So to me, lifestyle looks more attractive than metformin. Here's my semi-pithy conclusions. Remember, always recommend heart-healthy, calorically restricted programs to your patients, and the ones that will encourage the most adherence, happiness on their part, and that will change their objective heart-healthy numbers. These are the ones that I think patients should adhere to. What we know now is heart healthy is breast healthy, and probably it's also prostate healthy. And then after you talk about making these dietary changes, then you can discuss the benefits of exercise. I wasn't told to talk about exercise, on this lecture, but then you can talk about it. But first, remind patients what's important when it comes to diet, their adherence, their happiness, and that we change heart healthy numbers first and foremost. What's happened in the past few weeks, I think it happened on June 4th. Yes, it's there. Semaglutide, which is an injection that was used in diabetes, now got approved for weight loss. We should stay tuned. This is what's called a GLP-1 agonist. Some of the patients in these trials, including a large proportion of patients, lost 15% of their body weight. We've never seen that with a medication. So I don't work with this company. I don't know anyone at this company, but we need to watch this, because if we can translate that into the obese or overweight prostate cancer patient, get 15% weight loss by using a weekly injection, for example, we should watch this. There should be a trial done with semaglutide. And so I'm watching this very carefully, because I never got excited about weight loss drug before, but this is the first one that's showing numbers that really make a difference. Supplements, don't generalize about them. They could be bad or good about drugs. You know my philosophy. And remember always, I am the BFF of Dr. David Crawford, and that's according to Crawford only. I am the BFF of him. So I leave you with this. My Go Blue Dog, we're starting the meeting. Have a great meeting. I'm sorry I'm not there. David, I'm sorry I'm not there. To all my friends, I'm sorry I'm not there. But remember, I will probably see you at the winter meeting, and we will have a great time, and we will bond, and we will talk about the latest and greatest in prostate cancer. Remember, heart healthy is prostate healthy, and I'll see you next time.